May I invite Dr. Manu Varma next, Assistant Professor, Department of General Surgery, Government Medical College, Kozhikode.
Good afternoon. Respected teachers, dear colleagues, my dear friends, it's an honor to stand before this august audience to speak on a topic which is very dear to my heart. I'm bringing greetings from the home ground, Team Calicut, and greetings from Team Calicut to everyone present over here. So without further ado, let me give a few insights on this particular topic, that is diaphragmatic hernia presenting in adults, and transitioning some points which I've integrated and learned from my pediatric practice coming back to adult surgery. So over the next few slides, we'll be dealing about the problem, a few pointers on how a diaphragmatic hernia occurs, why it occurs, and what can be done when we are faced with this particular scenario. Many times it comes on an emergent basis. So we wouldn't, or the operating surgeon wouldn't have much of time to be prepared to deal with this presentation. So this is the diaphragm viewed from top down. I know it's pretty confusing and very overwhelming, this very crowded anatomical image. And this one is viewed from below upwards. So you have a lot of vital structures crossing across the diaphragm, crisscrossing through it, the various foramina. And to simplify it, let us focus on this image. We have the caval hiatus, we have the esophageal hiatus, and the aorta, which is sited behind the median arcuate ligament. The diaphragm is attached towards the lower ribs on towards the periosteum, and posteriorly via the medial and the medial arcuate ligaments over the paraspinal muscles. Now this is one image I want you to look closely and look at the branching of the phrenic nerve as it goes across the central tendon, and this is viewed from top down, and this is the manacles or handcuffs. So it resembles the appearance of a handcuff, and over here viewed from below upwards, again we can imagine a handcuff applied over the diaphragm across the central tendon. So this anatomical knowledge and orientation is something which will help us while we repair diaphragmatic hernia. Okay, a few pointers on the embryology. We all know it develops from the septum transversum, and this is the persistence of the pleuroperitoneal membrane which leads to a diaphragmatic hernia. And of course, the muscular component of the diaphragm also takes part from the cervical myotomes and the dorsal mesentery of the esophagus, and this development takes place by around 3 to 8 weeks of gestation. Okay, so this is a resultant image of a diaphragmatic hernia, the posterolateral one, or otherwise in adult practice we call them Bogdelic. It can be happening on the either side, right or left, more commonly on the left side. And we have the anterior herniation, or the foramen of Morgagni hernias, or the Lary hernias on the left side. Some pointers on the history. It was Sennertus in 1541 who described this problem, and it was Ambrose Paré who did an autopsy of a patient who died with a diaphragmatic hernia, and he described about it. So most commonly it is a delayed presentation of a congenital variant, a diaphragmatic hernia, or it could be acquired secondary to a trauma. And in fact, few cases have been reported diaphragmatic hernia happening to ladies during labor. And previous diaphragm surgeries or surgeries close to the diaphragm, and of course, eventration. Now, the relevance over here, because there aren't any definite guidelines how you can approach this particular problem, hence the talk. And of course, it's a very confusing area to many of us, and you need a very high level of suspicion to detect this problem. And even in traumas with patients who have undergone surgery, it might be missed during the primary surgeries, and many of the routine investigations do not pick up this problem. Now the diaphragm, it is one involuntary muscle that is absolutely resistant to fatigue. The moment it gets fatigued, you go into respiratory failure, and it is the major muscle of ventilation. So once a patient develops, because of sequelae of diaphragmatic hernia, it ultimately results in circulatory depression, respiratory depression, and a loss of function of the diaphragm. And also, it could be a strangulation of the herniated contents into the thorax. So that is also a problem. Now, so we have the intrathoracic abdominal contents which cause a lung compression, leading to a mediastinal shift and a cardiac compromise, being the ultimate reason why someone develops these problems. Okay. So what happens during trauma? So there is a sharing of the stretched membrane diaphragm, and the diaphragm gets avulsed from the points of attachment. And there is a sudden increase in the transdiaphragmatic pressure. Normally, we know the intrathoracic pressure is somewhere between -5 to -10 centimeter of water, and within the abdomen it is between +5 to +10. So there is a thoracoperitoneal pressure gradient of anything between 10 to 15 centimeter of water. So during this trauma, this gradient goes anyway up to 1000 centimeter of water. The diaphragm is designed to withstand a pressure of maybe 150, 200 or 250. That happens in a cough or etc. 1000 is too much for the diaphragm, even for the diaphragm to bear. And it's more common on the left side because obviously on the right side we have the liver protecting. Now the patient can present with respiratory distress, reduced breath sounds, they can have a bowel sounds in the chest, and you can have a paradoxic movements of the abdomen and thorax, vague, non-specific complaints. And very unfortunate presentation many times we see in the emergency is someone placing an ICD into the thorax, suspecting it to be a pneumothorax, and fecal matter or bile coming via the ICD as well. Very unfortunate. So some images showing diaphragmatic hernia seen on the X-ray, and here you can see the nasogastric tube on over here. So that is, of course, the CT is the best investigation to pick up this problem. Okay. Again, CT images of a diaphragmatic hernia. Now the management is very simple. All detected diagnosed diaphragmatic hernias need repair. There's no confusion. There is no conservative option for a diaphragmatic hernia. Everyone needs a surgical repair. And there aren't any contraindications for repair. Now what is the principle of management of a diaphragmatic hernia? It is a tension-free repair of the diaphragm, and with or without a mesh placement. Small defects, a single layer closure will suffice. A single layer closure in the form of a well-placed horizontal mattress suture or a figure of 8 suture. Even a simple suture will do sometimes. Larger defects, you might think of giving a 2-layer closure with or without a mesh placed. The rule of the thumb is any defect larger than 20 centimeters square, place a mesh. Now, how do you approach this problem? You can approach from below upwards or top down. That is, you can do a laparotomy or a laparoscopy, thoracotomy or thoracoscopy, combine a thoracotomy with a laparotomy, thoracoscopy with a laparotomy, or a thoracotomy with a laparoscopy, and or even a robo-assisted. So the situation, the surgeon expertise, and whatever is available in the hospital, and all this will determine, and what you're comfortable with as well, will determine how you approach this problem as well. And of course, how the patient presents. Because in a trauma, many a times it is, it is a prudent approach. It is prudent to approach the diaphragmatic hernia via laparotomy because you will be managing the intra-abdominal pathology as well. So in a traumatic setting, a laparotomy is preferred because you can also deal with the associated injuries. And also it is one familiar territory to most of us general surgeons. Okay. And once the defect with the herniated viscera is identified, we need to proceed with the reduction of the contents, which is perhaps the most difficult step in this problem. This is tricky because of the long-standing adhesions. So there is the option of cutting along the central tendon. This is where I mentioned about the phrenic nerve anatomy, not injuring the phrenic nerve. So once you can even widen the defect, and that will aid you in reducing the contents. And one point I want to stress over here is that you can pass some air into the thorax via a feeding tube through the side of the hernia, so that the negative intrathoracic pressure is negated over there, and that will help in the reduction of the contents. An image of the Morgagni hernia, which I operated in Thrissur last year, and so the reduction is the most difficult and the challenging step while we are approaching the diaphragmatic hernia. And when there is a difficulty, we might have to combine a thoracotomy, or a couple of slides, I'll just be fast. You might have to combine a thoracotomy or a thoracoscopy to aid in this reduction. Now, post-reduction, assess the diaphragm, assess the muscle image, the nature and the extent of the defect, and now is it a diaphragmatic hernia, plain, or is it with a sac? Now, we have to open the sac to visualize the lungs. And over here, you ask the anesthetist to give a positive pressure ventilation to assess the lung movement. If you don't get a lung movement, you are possibly dealing with a lung which is hypoplastic, means there's a poorer prognosis. Insert an ICD at this point and then proceed with the diaphragmatic repair, and rather than going the other way around. Now the sac, don't cut the sac at this point, because you'll need the sac. If it is there, it will help you in suturing, and you can also use it to buttress the defect. Okay, so over here you can see the surgeon lift up the sac which is herniated out over here. And over here, the suture material of choice is a non-absorbable zero-proline in adults. Again, interrupted horizontal mattress or figure of 8 sutures, or a 2-layer repair with placement of a composite mesh, and make sure that phrenic nerve entrapment or pericardial injury does not happen. Even if you don't have a composite mesh on emergency basis, you can place a plain proline mesh and cover it with the sac if it was there, or even place a peritoneal flap overlying the mesh so that it doesn't come in contact with the bowel. Over here you can see that the defect has been repaired and a mesh has been placed, and this is another patient with a mesh placed on the Morgagni hernia. Now, what can you do when you don't see a diaphragm at all, or where there is a very thin rim of diaphragm? You can mobilize extensively and even anchor the edge of the diaphragm if possible to the periosteum. There's no problem if it stays. Or there is an option of placing a very large mesh to replace the diaphragm. The other options are to operate with a transversus abdominis flap or an LD flap. Now, if you encounter the situation where you see malrotation as well, there's a very high chance for it as well. Do combine a few steps of the LADS procedure once you reduce the contents. So I guess this is the crux of the matter, and a couple of slides on eventration. The management is to plicate either from below or from above. The approach could be a thoracoscopy or a thoracotomy or a laparotomy or a laparoscopy. So that's the talk in a nutshell. I take a few questions. Thank you for this opportunity. Really enjoyed preparing for the CASICON and for this preparation as well. Thank you once again.
Excellent talk, Manu Varma. I think Vande Bharat and General Shatabdi left, you can go over it slowly. Busy people left the auditorium. Now, in adult patient without no symptom, asymptomatic diaphragmatic accidentally detected, will you suggest surgery?
It has to be suggested, sir. There is no role for conservative management in a diaphragmatic hernia that has been diagnosed. But for eventration, if the patient is absolutely asymptomatic at rest, then there is an option of following them up. If they develop symptoms at rest, then you have to also suggest an operative repair. Now, for someone with exertional dyspnea, on maybe when they do on a treadmill test and all that, maybe that you can follow them up. But symptoms asymptomatic at rest means you can follow them up for eventration.
Another point for the PGs: any patient from fall from the height, you should rule out diaphragmatic injury unless proved otherwise. Now, always take a CT, and as per the grading of CT, diaphragmatic injury score, with that you have to treat. Otherwise, patient develop the diaphragmatic hernia in futures. Always rule out diaphragmatic injury, patient fall from the height.
I deliberately deleted the slide of diaphragmatic injury, sir, because you didn't want to.
One more point I want to mention. Sure, you can cover the mesh by using the momentum, greater. You can well cover. You may raise the flap from the muscle, etc. You can cover the greater momentum, well covered. Nothing will happen. You covered with the momentum. Sir. And being a general surgeon, it is better to go through the laparotomy rather than a thoracotomy. Sir. Because you are very familiar with the laparotomies. Sir. You can easily repair by laparotomy. If you go to the thoracic part, thoracotomy, you can't see what is happening inside the abdomen. So always better to go to the laparotomy and do the correction. Otherwise, your laparoscopy surgeon both. Okay, this is Mason.
Ismail, sir.
Excellent presentation, Manu. For the eventation, symptomatic eventation, you can do the stapling. Either thoracoscopically or laparoscopically. Nowadays, you can put the stapler and you can avoid this suturing.
Okay, sir. Thank you, sir. Thank you for the input.
Thank you, sir.
Thank you, sir.
Thank you, Manu, for an excellent presentation of the topic. One question, because very often we find these diaphragmatic hernia pressing into casualty with the features of gangrene. So in that situation, how will you manage? Will you use a mesh? Suppose you need a resection of the bowel. Will you use a mesh, or you attempt some other method to correct the defect?
Sir, ultimately that depends on one, the condition the patient arrives and the gap between the edges of the diaphragm. Sir, many times if it is as a sequelae of trauma, sir, if it's as a sequelae of a trauma, there is an emergency scenario where we are forced to approach via laparotomy and deal with the associated bowel injury. Yes, in that scenario, I will be skeptical in placing a mesh, considering all the problems of a mesh infection. Sir, that's all. I'll have to do it on an individual case-by-case basis, sir. There is a lot of contamination. Mesh would be, better avoided, sir.
Before the era of the mesh, we used to close the defect with number 1 proline in 2 layers. That's also a good step. Then you reinforce the area with omentum. That was one method we used to do when the meshes were not available.
Thank you, sir.
Thank
Thank
you,
you,
sir.
Manu Varma.
Can we move on, sir?